Hello friends, today we are going to discuss about the preload responsiveness. Volume expansion, the first line treatment of the acute circulatory failure can be the source of crucial therapeutic dilemma. On the one hand, the severity of the disease incites one to initiate treatment rapidly and massively. In line with this, the pivotal study by Rivers et al. Showed that massive fluid administration during first 6 hours of the resuscitation of the patient with severe sepsis and septic shock was associated with improved outcome. The response to the fluid challenge is complicated by the cardiovascular physiology. Due to varying shapes of the Frank-Starling curve could take depend on the ventricular systolic function. Fluid challenge could lead to either significant or negligible increase in the stroke volume and cardiac output. If no attempts are made to predict the response of the cardiac output to volume expansion, fluid responsiveness occur in only half of the patient. So, volume expansion failed to result in significant hemodynamic improvement. It inherently leads to hemodilution, to increased cardiac filling pressure, and eventually to the fluid over. All these facts taken together lead to one view fluid therapy as any other medication, which must be neither overdosed nor underdosed. So, this is the pictorial representation of the Frank Starling curve. As we can see, the above two lines, which showed significant response of the fluid challenge, and the below two lines showed the no response of the fluid challenge. Now, how to assess this fluid responsiveness? So, there are two methods, static and the dynamic. Static method to assess the fluid responsiveness are pressure. Both systemic central venous pressure and the pulmonary artery occlusion pressure were reported to be the poor value in the prediction of the fluid responsiveness in both spontaneously breathing and mechanically ventilated patients. Areas and the volume, although they were considered to be good indicator of the preload, cardiac dimensions like left ventricular end diastolic area and the left ventricular end diastolic volume were reported as poor predictors of the fluid responses. Now about inferior vena cava, maximum diameter measured by the ultrasound at subcostal area and vascular pedicle width measured from the chest X-ray has gained popularity in the assessment of the volume status. Moderate evidence is available suggesting that IVC diameter is lower in the hypovolemic patient. The role of vascular pedicle width is more evident in patient with the volume over. There is no evidence suggesting the role of absolute IVC diameter or vascular pedicle width in the prediction of the fluid responsiveness in shock patient. Now the limitation of the static measures. Many reasons describe why parameters are of poor value in the prediction of the fluid responsiveness. First, cardiac filling pressure represents intramural pressure. However, preload is determined by the transmural pressure, which is affected by both intramural and extramural pressure. Second, preload alone cannot predict the fluid responsiveness because the response of the patient to the fluid depending on both preload and the cardiac contractility that varies between the patient. Preload will predict the fluid responsiveness only in the cases with normal ventricular contractility. Now about dynamic measures to assess the fluid responsiveness. Physiological basis. Fluid responsiveness is detected by inducing change in the preload and subsequently monitor the corresponding change in the stroke volume and one of its derivatives. The change in the preload is achieved in the dynamic measure by positive pressure variation. Positive pressure variation provokes a cyclic decrease in right ventricular stroke volume via two mechanisms. One is decreased preload and the increase afterload. So RV stroke volume reaches its maximum value by the end of inspiration, resulting in consequent decrease in the LV filling and thus LV stroke volume after a lag period of 2 to 3 heartbeats. Two other mechanisms were mentioned to antagonize the negative effect of mechanical ventilation on stroke volume, that is squeezing of the blood out of the alveolar vessel and thus transiently increasing the LV preload. Inspiratory increase in the pleural pressure that decreases the LV afterload and enhancing the LV ejection. But later two mechanisms have only minor effect on the LV stroke volume. So the net effect of positive pressure ventilation is decrease in the RV stroke volume, LV feeling, and LV stroke volume. So how to measure this? So how to measure the fluid responsiveness? The first variable is systolic pressure variation. Systolic pressure variation is calculated by measuring the difference between both maximum and the minimum values of systolic blood pressure during single respiratory cycle and the reference value. The reference value is the systolic blood pressure measured at end expiratory pause. So systolic pressure variation was reported to increase with induction of hypovolemia in mechanically ventilated dogs and mechanically ventilated patient after aortic surgery and patient with the septic shock. Now about pulse pressure variation. Pulse pressure variation is calculated by dividing largest pulse pressure by average pulse pressure. So pulse pressure variation above 13% is a good predictor of the fluid response. So pulse pressure variation has advantage over systolic pressure variation of not being affected by airway and pleural pressure because these pressure affect both systolic blood pressure, diastolic blood pressure, where the pulse pressure remains unaffected. In the intraoperative situation, pulse pressure variation showed low accuracy with the patient undergoing GI surgery. So pulse pressure variation was accurate after cardiac surgery only when patient with the low perfusion or right ventricular dysfunction were excluded. Now the stroke volume variation. Stroke volume variation is commonly measured by pico-continuous cardiac output monitoring or esophageal Doppler. It is calculated by dividing the difference between maximum stroke volume and minimum stroke volume and by their average in a time window of 30 seconds. So stroke volume variation was reported as a good predictor of fluid responsiveness in brain surgery patient, general surgical patient, septic shock patient, and after cardiac surgery. So stroke volume variation was not accurate with patient with undergoing GIT surgery. A recent meta-analysis reported a stroke volume variation as a reliable predictor of fluid responsiveness in mechanically ventilated patient on tidal volume above 8 ml per kg and the proper cutoff of 14% for stroke volume variation and 11% for stroke output index. Now the plethysmographic dynamic indices. Pulse oximetry plethysmographic waveform amplitude is measured using special pulse oximetry sensor. Plethysmographic variability index is more easily measured using Mosimo device. This both pulse both POP and pulse variability index were reported in the recent meta-analysis as a good indicator for fluid responsiveness in mechanically ventilated patient without cardiac arrhythmia, heart failure, or spontaneous activity in cutoff value 9.1 to 15%. So, plethysmographic variability index measured before induction of anesthesia predicted propofol-induced hypotension during induction of anesthesia. So, plethysmographic variability index showed low accuracy in the detection of fluid responsiveness after cardiac surgery. Now, IVC respiratory variation. IVC variation is the best assess using ultrasound in the long axis view. IVC diameter is measured 1 centimeter distal to the junction with hepatic vein either by 2D or M. Although data about IVC variation in the fluid responsiveness are heterogeneous with regard to type of patient, type of fluid, and definition of collapsibility index, there is consensus that cutoff value of 12 to 21% for IVC variation is useful in the detection of fluid responsiveness in mechanically ventilated patients. In spontaneously breathing patient, a more cautious use was suggested by Mueller and co-worker who reported IVC variability of more than 40% to predict the fluid responsiveness. They also suggested that low values of less than 40% do not exclude the fluid responsiveness. Now, SVC variation, respiratory variation. SVC variation predict the fluid responsiveness with cutoff value that range from 29% to 36%. So variation in the peak flow velocity in the SVC predict fluid responsiveness at cutoff value of 12.7%. Now, internal jugular vein and subclavian vein respiratory variation. IJV distensibility measured using ultrasound was recently reported as predictor of fluid responsiveness in mechanically ventilated patient with cutoff value of 18%. The combination of IJV distensibility of 9.7% and positive pressure pulse pressure variation of more than 12% reaches the sensitivity of 100% and specificity of 95%. Recently reported that IJV collapsibility index to overestimate the collapsibility when compared to IVC. They also reported weak correlation between IJV and IVC collapsibility, raising controversy about IJV used in the prediction of the fluid response. Subclavian vein collapsibility was also reported as alternative method to detect fluid responsiveness with advantage of having easy and fast access than the IVC. Now the subaortic velocity time integral variation. Subaortic velocity time integral variation was reported as a predictor of fluid responsiveness. However, it has not been tried in human yet. Now, aortic velocity variation. Respiratory variation of the peak aortic velocity was reported as a good indicator of for fluid responsiveness in critically ill patient under mechanical ventilation. The best cutoff value was 18% when measured by esophageal Doppler and 12% when measured by transesophageal echocardiography. In study conducted by Dumont et al., peak aortic velocity measured by esophageal Doppler did not predict the fluid responsiveness during surgery. Carotid artery peak velocity. Variation carotid artery peak velocity measured using ultrasound was recently reported in two observational studies to predict fluid responsiveness in patient undergoing coronary artery bypass grafting surgery as well as patient with the septic shock with cutoff value of 11 to 14% respectively. Now limitations of the dynamic measures. Spontaneous breathing. Spontaneous breathing is the most important limitation of dynamic methods. The failure of dynamic method to detect fluid responsiveness was reported in patient with spontaneous breathing as well as patient on pressure support ventilation. This was explained by the dependence of dynamic parameter on the regular variation in the intrathoracic pressure, tidal volume, and rate. All these components are highly variable in spontaneous breathing patient, in addition to the effect of abdominal muscular contraction and the on preload response. Ventilator related causes. Dynamic parameter poorly detect fluid responsiveness with tidal volume below 8 ml per kg and patient with a low airway driving pressure below 20. This was explained by the fact that low tidal volume induces small variation in thoracic pressure and consequently small changes in the preload. So with tidal volume below 8 ml per kg, fluid responsiveness is present even with lower pulse pressure variation. So the cutoff value of prediction of fluid responsiveness with low tidal volume should be 8% and not 12% as a higher tidal volume. So the failure of dynamic method was also reported in case with the high frequency ventilation. This is because low number of cardiac cycle per respiratory cycle will not allow respiratory variation in stroke volume to occur. Now low lung compliance. Dynamic methods for detection of fluid responsiveness were reported to be low value in cases of reduced lung compliance, especially in case of low pulse pressure variation. However, presence of high pulse pressure variation in patient with ARDS is an indicator of fluid responsiveness when patient's tidal volume is above 8 ml per kg. Now the next is elevated pulmonary artery pressure. Pulse pressure variation poorly predict fluid responsiveness in patients with the elevated pulmonary artery pressure. These patients usually do not respond to fluid resuscitation. Now about cardiac causes. Dynamic measures are not valid in case with cardiac arrhythmia and variation in the stroke volume in this case is influenced by the irregular rhythm rather than heart-lung interaction. Pulse pressure variation was not able to predict fluid response in patient with the elevated LV pressure defined as E by E prime more than 50. Both pulse pressure variation and the stroke volume variation were altered by propranolol-induced acute ventricular failure in mongrel dogs. Now, open chest condition. Neither pulse pressure variation nor SVV was able to predict fluid responsiveness under open chest condition, and this was reported in patient undergoing CABG surgery during thoracotomy. So dynamic method showed the good response in same patient group after chest closure. Now intra-abdominal hypertension. Increased intra-abdominal pressure above 10.5 mmHg impairs the accuracy of the pulse pressure variation. A one-day prospective multicenter study reported that only 2% of patients with acute circulatory failure in the ICU have fulfilled the validity criteria for valid application of pulse pressure variation. This finding increases the interest in the fluid challenge method to overcome the known limitation for dynamic methods, especially outside the operating room. Now, the preload and the fluid challenge. Physiological basis. Fluid challenge method are done by administration of the fluid bolus and monitoring the resulting effect on stroke volume or cardiac output. Fluid responders are patients with 15% increase in stroke volume or cardiac output after fluid challenge. Stroke volume or cardiac output can be measured using transpulmonary thermodilution, pulse counter analysis, bioreactance, and echocardiography. Alternative parameters to detect patient response to passive leg raising include the following: decreased pulse pressure variation uh, and stroke volume variation, increased radial pulse pressure, femoral artery peak velocity, carotid artery Doppler, and peak velocity. Recently, the indirect methods of measurement of cardiac output response to PLR were introduced. These include end-tidal CO2, mixed venous O2 saturation, sublingual microcirculatory perfusion, and skin perfusion. So these are the dynamic methods for detection of the fluid responsiveness. Stroke volume, systolic pressure variation. This is affected by airway and the pleural pressure. PPV needs special monitor, needs art line. SVV, the limitation is it needs either art line and esophageal Doppler. Then stroke volume index needs esophageal Doppler. Then pulse oximetry plethysmography waveform. It also needs pulse oximetry. Then plethysmography variability index. It needs a Massimo device. IVC variation needs ultrasound, difficulty in abdominal surgical cases, and cannot be used intraoperatively. SVC variation needs transesophageal echocardiography. IGV variation needs ultrasonography. Subaortic VTI needs echocardiography, need good operator experience, and it is not tried in human yet. Aortic velocity variation needs echocardiography and esophageal Doppler. Carotid velocity variation needs ultrasound. Now measures are passive leg raising. Passive leg raising creates the transient increase in preload via translocation of the venous blood from the lower limb to the thorax. It has been described as an attractive method of fluid challenge, having advantage of being self-volume challenge or reversible fluid challenge. PLR-induced increase in the stroke volume can determine the fluid responsiveness in most situations that dynamic method fail to deal with, such as spontaneous breathing, decreased respiratory compliance, and cardiac arrhythmia. The best cutoff for detecting fluid responsiveness is increased aortic blood flow by 10% or increased cardiac index by 10% after PL. Now, end expiratory occlusion. End expiratory occlusion is done by interrupting mechanical ventilation at the end of expiratory pause by 15 seconds with monitoring stroke volume and its derivative. End expiratory occlusion is considered another method for self-fluid challenge as it attenuates the inspiratory increase in thoracic pressure resulting in increasing venous return. So end expiratory occlusion induces increase in cardiac output by 5% and was reported to predict fluid responsiveness in most patients in whom dynamic measure fails, such as patient with arrhythmia, decreased respiratory compliance, and ARDS patient. End expiratory occlusion can be used in patients with spontaneous breathing activity unless excessive triggering result into test interruption. It showed same accuracy as PLR when response to both of them was assessed using cardiac index. End expiratory occlusion is superior to PLR if response was assessed by changes in arterial pulse pressure, and this was explained by PLR-induced change in arterial compliance, which impairs the ability of arterial pulse pressure to reflect the changes in stroke volume with the PLR. However, PLR has an advantage over end expiratory occlusion in being applicable in non-intubated patients. Although Gunot et al. Reported a poor value for end expiratory occlusion in the prediction of fluid responsiveness in operating theater, this finding was reported in operated patients with no signs of shock. PEEP-induced hemodynamic change. Increasing PEEP by 10 cm produces hemodynamic effect that is near to end expiratory occlusion. Gates et al. Reported fluid responsiveness can be predicted in cardiac surgery patient if increasing PEEP by 10 cm of water for 5 minutes produce increase in CVP with area under curve of zero point 0.9. However, no data is available about the cutoff value of change in CVP that would predict the fluid responses. This method has an advantage over end expiratory occlusion of not being affected by ventilatory condition, easily done in the ICU patient with no need for any advanced monitor. Another method of detecting fluid responsiveness was reported by Wilkman et al. In patients with septic shock by increasing peak from 10 to 12 and following their map. A negative predictive value was 100%. So the absence of decrease in the map during PEEP elevation can identify non-responders. Arm occlusion method. Arm occlusion method is defined as radial artery pressure after 35 seconds occlusion by blood pressure cuff. It is measured using arterial catheter. Arm occlusion pressure is considered as an indicator of mean filling pressure and volume status of upper limb. Arm occlusion pressure of less than 21.9 mmHg detect the fluid responsiveness in cardiac surgery patient. Now about mini fluid challenge. Mini fluid challenge is performed by infusing 100 ml of colloids over 1 minute with concomitant monitoring of aortic velocity time integral. Increasing the VTI by 10% after a mini fluid challenge predicts the fluid responsiveness. Now 10-second fluid challenge. Infusion of 50 ml of the crystallite with monitoring of the cardiac output and stroke volume was recently reported as a method of detection of the fluid responsiveness. The best cutoff value was 9% in cardiac output and stroke volume after fluid administration. Now, limitation of the fluid challenge technique. The main limitation in using fluid challenge method for detection of fluid responsiveness is the need for real-time monitoring of stroke volume and cardiac output to differentiate fluid responders. Alternative less invasive parameters are being introduced to trace patient response to PLR such as end tidal CO2 and peak velocity in the different arteries measured by ultrasound. Effect of vasopressor on different method of detection of fluid responses. Norepinephrine infusion decreases the pulse pressure variation and stroke volume variation, masking their ability for detection of fluid responsiveness. This finding was addressed in two experimental animal studies on dogs and pig. Moreover, measurement of stroke volume using flow track and the Vigilio system is not accurate under condition with increased vasomotor tone due to phenylephrine infusion. On the contrary, PLR test kept kept its value as a predictor of fluid responsiveness in patients with septic shock, even after increasing norepinephrine dose. So, fluid challenge method for detection of the uh, fluid responsiveness. One is PLR. So cutoff value is 10% increase in aortic flow or cardiac index. It is not feasible in the intraoperative situation and some surgical patient need cardiac output monitoring. Now end expiratory occlusion pressure, 5% increase in cardiac output. It needs mechanical ventilation, needs cardiac output. Now PEEP induced increase in CVP. Cutoff value is 1.5 mmHg. Tried only in cardiac surgery patient. Now, PEEP induced decrease in the map. It is useful in identifying non-responders. Arm occlusion pressure, cutoff range is 21.9 mmHg, tried in cardiac surgery patient. Mini fluid challenge, 10% increase in the subaortic VTI, needs echocardiography with experienced vent operator. 10-second fluid challenge, cutoff value is 9% increase in cardiac output and stroke volume. It also needs cardiac output and stroke volume monitoring. Thank you, guys.